Okay, thank you, Joel. So let's start by just concentrating on what are the ways for us to think about optimizing drug therapy in an IBD. I think overall the schema of management really needs to focus on kind of multiple tiers as we approach the IBD patient. We need to think about choosing therapies that are based on prognosis as well as severity. I think one of the key aims of the future is really going to be, as we're going to have multiple targets, is we're going to have to figure out which patient is at highest risk for developing a complication and which therapy would be most appropriate to prevent that complication. We want to use objective endpoints, and Jim spoke clearly on role of mucosal healing and introduced the STRIDE guidelines that have been suggested as a way of thinking about how to achieve your target and when. Understanding risk in the context of disease risk, I think that's some of the things we most struggle with, is how do you actually put that context of that the disease itself is always riskier than the therapy that we're talking about. Adjusting therapy serially, meaning not allowing the patient to drift too much, and tomorrow I'll talk a little bit more about treat to target, and optimizing therapies to match disease severity and inflammatory burden. So I put on the right here, I have this idea that there's this proactive versus reactive, and I think everyone agrees that we've made a huge adjustment in our management of IBD patients and have thought much clearer about the proactive ability of us as clinicians and healthcare providers of IBD patients, that we have tools that we can currently use to literally know when a patient is going to flare. And tomorrow, again, I'll highlight that. And the ability, also the tools to predict risk, which Robin, I'm sure, alluded to. So the fact that there's tools now, and it's only going to even be much better as we develop decision support tools for the web, is going to be an exciting movement into the space of being able to have patients and physicians really be on the same page about how to match their disease severity burden with the therapy of choice. So let's dive right into therapeutic monitoring and thinking about today, what do we know? And a lot of this is just a reminder of what you already know, is imagine that 10 years ago was the idea put forth that if you would check a drug level at the time that someone is getting their infusion, and the concept that someone who had detectable drug levels, not a cutoff of 3, 4, 5, just the idea that the drug was present, patients had better outcomes. That's like an intuitive idea that was put forth in 2006. This was on the tails of us starting to use thiopurine drug monitoring in the first part of 2000, 2005. The idea that, again, if you got a therapeutic 6-TGN level, that patient would probably have better outcomes. So it was akin to that relationship that there was a detectable drug level. We didn't quite have a therapeutic range back then, but now I'll walk you through how the cutoffs have evolved. But this was looking at both remission and endoscopic improvement. And as the drug level was higher, patients did better. And then published back in 2014 was also looking in ulcerative colitis. The first data I just showed you was in Crohn's disease, as a reminder that in the Act 1, Act 2 ulcerative colitis trial, at 6 months, the steroid-free remission rate was 24%. Now, the main reason why your patients go on biologics is because they would like to be in steroid-free remission 100%. The concept that in UC, although p-values were met, the clinical implications of just getting a quarter of your patients to reach the outcome of interest was concerning. As we started to understand that it was probably all tied to how much drug the patient had in their body, and that if their patient had more drug at the time of assessment, they probably had higher remission rates. And lo and behold, if you look at week 30, which was the primary endpoint, you could see that patients, if you did quartiles, so the top half of patients above the median, for example, those patients had much higher remission rates than individuals who were in the second quartile, and those patients in the first quartile look almost like the placebo rate. So it's very convincing, and this has been replicated with every single drug trial that it has come to, that we've seen the data. and the Stelara or ustekinumab data is going to look the same, and every other drug trial that's going to come out that uses a biologic-based monoclonal will look exactly the same. The lower the drug level, the less the response. So just remember that that theme applies no matter what drug we're looking at. Obviously, the small molecules will be a little bit different because they aren't quite a biologic-based monoclonal antibody. So we talked about kind of remission. Now, mucosal healing is always a question. There hasn't really been a lot of data on what level of infliximab per se has been tied to mucosal healing, but there's been more recent suggestion that we may find a adalimumab level that may be tied to mucosal healing. Because I think we've kind of been used to looking at infliximab level reports. We know what an anti-infliximab level looks like when we look at a report because we've been used to ELISAs, doesn't matter what company is actually running it. We're kind of familiar with it. But the adalimumab levels has been really just introduced probably in the last 2 years. It's relatively new to our understanding. And the one thing we do know about adalimumab levels is we think we have a floor, but we don't think we have a ceiling. What that means is I don't know if a level of 22 means anything different than a level of 10. I don't know. Maybe some people do need a level of 22. I have no idea. There's no data to support that higher levels are bad, just to give you that concept that we don't know what the tip of the iceberg is, and we don't have a therapeutic range for adalimumab, but we do know, and most studies have proposed, this is one study that showed a level of 6.5 was the median in patients who had mucosal healing, but it looks like more recent data supports that a level closer to 10 is more accurate to determine mucosal healing in someone on adalimumab. I just wanted to show you the Entyvio or vedolizumab trough concentrations similarly has a trend, and if you look particularly at CDAI response, meaning a 100-point change, you could see clearly that as you get higher drug levels, the response becomes higher. And as I said, you'll be seeing similar with golimumab, which I don't think I included, but that was published in the original golimumab article for UC. It looked exactly the same. So the question remains is that as we move forward with new biologics that will be coming to market, I think one of the important things we need to stress to any lab is that we need a partnership with a drug level, because without knowing what the drug level is, and if a label is constrained by the inability to escalate, it's a problem, right? So, for example, the vedolizumab label does not allow you for Q4 week. It's not in the label. Some of us are able to fight the insurance companies because patients are breaking through before the 8-week mark, but it's not like the flexibility we're used to when it comes to, for example, infliximab. So there's a huge push, not just to commercial labs, but to the companies themselves to try and have a companion assay that will help us understand how we can use these drugs better. So that's really in the background noise that we're all creating with a lot of these pharma who want to know how much we care about drug monitoring. So in order to understand why people have certain biologic different activities as it relates to drug levels, just let's review the understanding of what are the drivers of pharmacokinetics in individuals on biologics. This is a list that was put out by Ordaz in 2012. I just want for you to pay attention to the idea that we know, and we've learned this way back, that if you have anti-drug antibodies that's kind of Pac-Manning away or getting drugs out of the system, it could make sense that it'll result in lower drug levels. I think that's the one thing we first learned way back and we felt the most confidence in. But then also from some of the trials, such as the SONIC trial, patients who were on concomitant immunomodulators did better than patients who were on monotherapy. So the concept that adding another drug, potentially something that actually influences the immune globulins or maybe impacts the clearance of drugs, improves the pharmacokinetics. This was interesting. Someone who has very high baseline tumor necrosis factor measured in their serum and or in their tissue has been shown to be associated with more rapid clearance of the drug and less effectiveness of the drug. Low albumin, those of you who've heard me speak about this concept that in a sick UC hospitalized patient, high CRP, low albumin, a lot of TNF concentration in the tissue, and that tissue is just going to eat up every ounce of that drug you give them, the concept that you have much more rapid clearance and the need for higher drug. Also, patients who that was the high CRP and low albumin, high BMI actually increases clearance. So that was part of the trouble with adalimumab in ulcerative colitis, and they showed that individuals who had a kilogram weight above 70 kilos, they had worse outcomes than patients who were less than 70 kilos. So the idea that higher BMI may be impacting the way you clear, and males have higher clearance than females. So if you have a sick UC patient who has a BMI or has a, whose kilogram weight is 90 kilos and is a male, there's no way on-label dosing is going to help this individual. So it's really important when you think about managing and optimizing therapy, you need to think about the individual that's sitting in front of you in order to make the right decision on dosing. This goes back even to 2003 when the first reports that antibodies actually impact how long a patient stays. Can I have some water? Sorry, thanks, Joel. Or you can bring my tea that's behind Robin if you want. Thank you. The idea that when patients had antibodies, they actually had shorter time in between, thank you so much, in between the need for their next infusion. It makes sense. You get a boatload of drug, then as the drug comes down and it's cleared quickly, the antibodies kind of come in and patients flare. So this story goes back even before the whole drug level concept, thank you, of, well hydrated here, the drug level concept in 2006 that good drug levels correlated with efficacy. The whole antibody story started back in 2003 when episodic treatment was what was the norm in Europe, because they had maintenance approved long after we did in the US. So they were seeing episodic treatment and figured out that patients who developed antibodies flared earlier than people who didn't. That's the antibody story. It goes back now 13 years. And then we also showed historically, just a plug on the concept that all monoclonals are probably the same. I don't think, and my AbbVie colleagues in the room could appreciate that the term that we're human and they're chimeric is not really something that you hear. That's not a conversation anymore. Listen, no one has been immunized to create their own anti-TNF, right? So these are all foreign monoclonal proteins that are placed in an individual body. It doesn't matter if it's a superhuman, if it's 98% human, or 75% human. Antibodies are formed. What we started to learn is that the type of assay that was used to measure the antibodies were what was tricking us into imagining that those drugs that were human didn't have as much immunogenicity or antibodies against the drug as Infliximab, for example, which would be the standard to which it was compared. Well, when you were able to use a more drug-tolerant assay, this is the Prometheus assay in particular, but any of these evolving drug-tolerant assays, the antibody rate to adalimumab is exactly the same as it is to Infliximab. There's absolutely no difference when you use the right assay. Sure, when you use the wrong assay, it looks fantastic. It looks like about 2% of people get antibodies. The good news is some of the future therapies that are out there have lower immunogenicity as well that will be coming to market. There was the other question about how many of these antibodies stay, how many are transient versus how many are what we call sustained. Because if you have a patient who's got really good drug levels and has a low level of antibody, you're like, what's this guy doing? Why does this individual have both antibodies and drug levels? And the thing is, when you have these drug tolerant assays now, you could see both in the same patient. And the question is, are those antibodies meaningful? Maybe they're not neutralizing antibodies. Maybe they're actually not neutralizing the drug. And some would say, as long as you have drug level, you're okay. That remains to be seen, because if you have someone who has a drug level of only about 5 and has an antibody level of 5, that patient's probably not going to do very well. But if your patient has a drug level of 15 and an antibody level of 3.9, I don't really get too excited about that concept. So it does take into account kind of thinking about next time, hopefully that antibody will be gone. You know, that's that concept of sustained versus durable. And we know from this paper that those patients who got antibodies within the first 6 months tended to be more sustained. And if you had an antibody level that was greater than 10, it was more often going to be sustained. So those are the two kind of hints in terms of what antibodies are likely sustained versus what antibodies are transient. This goes back to that clearance story I was giving you, that 90-kilo male, low albumin. Joel Roche sent an email asking our thoughts on a kid who had a albumin of 1.9, and Joel, I'm going to guess his CRP was elevated as well, very elevated. I'm getting the oh yeah face from Joel. And the concept of, do you keep just drugging him and keep giving him every 3 days a new dose of Infliximab, go up to 20 milligrams per kilogram? The concept is very clear, that the half-life of someone who does not have low albumin, high CRP, sick UC, pancolotic patient, the half-life's about 2 weeks. But in Joel's patient, the half-life was about 1.4 days. 5 half-lives till drug is gone. That means drug is completely gone by day 5. So are you going to just slog the system and keep giving drug with the hope that you'll eventually get rid of enough inflammation to raise the drug level? I know there are people that do it, but typically at the end of the day, that patient does not save themselves from colectomy most of the time. You may get them out of the hospital and think that's a success story, but just see what happens when they come back after maintenance, right? And as they wean their steroids. So you've all probably had experience with this very sick UC patient, and plus 20% of them already have antibodies at week 6. These are patients that are just clearing the drug so quickly and they're really developing a lot of immunogenicity. Where is the Infliximab going? The Infliximab is going in the stool. So it is processed literally through the colon, which is a site of activity, which actually processes the clearance of the drug predominantly at sites of inflammation. It's counterintuitive to what you would like to happen, but in a pancolonic patient on day 1 who gets a dose of IV Infliximab, there's more Infliximab in the stool than there is in the serum. So basically, the question is, how do you balance what dose you would use in a patient who you know is going to have a lot of fecal loss, and what's the best way to approach this exact kind of patient that Joel had reached out to get our thoughts on. The reason why tissue levels are important, this was a recently published article in Gut by the group from Miami, Maria Abreu and Dr. Yarur, and basically they actually showed that patients who have higher degrees of inflammation, it kind of made sense in terms of the pharmacokinetics of it is that there is so much TNF sitting in inflamed tissue that you need that much more drug to overcome the level of TNF that is sitting in the tissue, and plus you have the loss of the drug through the inflammatory pathways of clearance. Some would say we need better tools of knowing who should be escalated, who should be treated, and who should go straight to colectomy. And that, I think, is something that models are being developed to look at what is the right dosing and what are patients that we should just go straight to colectomy. So we're going to move to this idea of, is concomitant immunomodulators necessary? About 3 hours ago, a presentation was made at ECHO, which was a presentation on the risk of lymphoma, malignancies, and HLH in children exposed to thiopurines versus anti-TNF therapy, which showed that thiopurines were the predominant, was involved in, the ones we reported as of today, were involved in every malignancy or every lymphoproliferative disorder of the 5,000 children followed for 25,000 years of follow-up to date, patient years of follow-up. And the idea, so if you go back to Sonic, and for pediatricians in the room, I think we may think a little bit differently. I approach probably younger pediatricians, still not young, to think about under 35, where the risk of malignancy and lymphomas is still elevated with thiopurines. But the whole concept of the pendulum of do we use concomitant thiopurines or not, in 2006, when hepatosplenic T-cell lymphoma was first reported in 6 children, those were the first. I would like you to know that every single case after those first 6 have not been in children, and that the average age is 25. So for my adult colleagues in the room, recognize that the case of HLH are actually happening in 20s-year-olds and not in 15, 6, and 11-year-olds, like the first 6 cases were reported. And the idea came from the fact there was this pendulum swing when Sonic was published saying concomitant immunomodulators will help your Infliximab work better, so you should go back to using concomitant. Okay, so the concept was, well, was it because 2 drugs are better than 1, or was it because truly that the second drug was helping the first drug work better? You know, that concept of, was there some immunogenic protection when you're using immunomodulator? And this is Sonic, which probably most of you have seen, but just as a reminder that the antibody data was very clearly to me, the reason why concomitant was better, and it was showing you here that the rate of immune antibodies against infliximab was 14% in patients who were on monotherapy infliximab versus 1% when you were on combo. So that accounted for a 14% difference, or 13% difference, or 14-fold increase of the antibodies. And funny enough, the delta between the efficacy of combo versus mono was about 13%. So some would ask, do we really need 2 drugs at its full dose to really have the effect, or do we just need to find a way to optimize the biologic-based therapy? That's really, I think, the question of the day. So it also showed that it increased the trough level. Again, when you have better drug levels, you have better outcomes. So again, the idea that concomitant helped you get better drug levels and less antibodies. Now, the COMMIT trial, which everyone thinks shows that concomitant methotrexate was a negative trial, needs to be very clearly interpreted. The outcome at 1 year did not show, like Sonic, that using methotrexate in combination with infliximab was any better than using infliximab alone. But what was not said is that the patient population was completely different. A third of patients who entered the trial were in remission. You didn't need to have active disease, and I could go on and on about the study design being different. But what I can tell you is that even though the efficacy and primary outcome was no different, the drug levels were different, meaning the outcomes were better in people who were on concomitant methotrexate. And that has been repeated 3 or 4 more times, that patients on concomitant methotrexate do the same as if they were on concomitant immunomodulator, and that is driven by the protection against antibodies for these therapies. This was one of the original studies that kind of noted the idea that, hey, if you have someone who's on monotherapy, developed antibodies, low drug levels, you could just add an immunomodulator, and then you actually can reverse this ratio of antibodies to drug levels. And the group from Israel showed that when they added methotrexate, the antibodies decreased, added AZA, antibodies decreased, started 6MP, antibodies decreased, drug levels increased. So this concept of, can I add an immunomodulator rather than dose escalate everybody in someone who may have lowering drug levels but some low-level antibodies, adding an immunomodulator may be the right choice. Everyone always asks, do I need, based on Sonic, if I am going to use immunomodulators, do I need to use 2.5 milligrams per kilogram based on the Sonic trial? Because that's what they used. Well, again, Maria and her group from Miami actually said, you don't need to worry about dosing, just get a good drug level of the 6-thioguanine. Get a drug level of at least 125, and that correlated with the lowest time frame of having antibodies against the anti-TNF therapy. So it could be that the safety of the combination would be improved if we just didn't use full-dose immunomodulators, full-dose Imuran or 6-MP, for example, and just try and get a minimum level of 125. And this is from Dave Rubin's group, and we've replicated it as well, that at least 15 milligrams, you probably don't need more than that, but 15 milligrams PO weekly of methotrexate has shown to be protective against antibodies compared to low dose, which was 7.5 milligrams PO weekly that we used to use when we all first converted ourselves from thiopurines over to methotrexate. This gets back to this idea that can it be that if I change the frequency of the way I dose Infliximab in a patient who needs to be rescued, will that actually help me get them away from a colectomy? And I can tell you that at DDW last year, the group from Ireland showed very promising data for just short term, meaning within the first 30 to 60 days after admission, that if I used 3 doses of Infliximab within a month, just gave them the dose every time they said they were sick, rather than the standard 0-2-6 regimen, I got them out of the hospital colectomy-free. Well, guess what? At a year, there was no difference in colectomy-free rates. So it gets back to, again, the question, do we know who that patient is who needs accelerated dosing, and what does the dosing really mean? So let's finish by thinking about clinical practice. So the reactive monitoring approach to IBD management, which goes back to this pyramid approach, which those of you who've been to many symposiums dating back probably even within the last decade, remember that the therapeutic approach to IBD was that step up, use the safest, least effective therapy, even for the sickest patients, wait for them to tell you that they needed something else, try the next thing, keep your fingers crossed. It was that fingers crossed phenomena of step up, safest but least effective. Same thing happened with drug monitoring. We were waiting for people to fail, get a drug level and say, guess what? You have low drug levels, right? It was that's what our algorithms told us. We said, wait to get the person to not respond, get a drug level. If they're antibody positive, switch to another anti-TNF or potentially out of class. If they have high drug levels, they probably need to be reevaluated. Maybe they're primarily failing the drug. Or if they have low drug levels and no antibodies, dose adjust. But you waited for a patient to fail and potentially have antibodies, right? So that was the reactive approach to IBD management. Well, last year we reported in the IBD journal that serendipitously, I had collected samples from week 14 in an NIH grant that started in 2009. But it was another project that I was asking the question, but I happened to be getting drug levels at week 14, and I followed patients for a year. I was blinded to the drug levels. Then finally, after the project was done and we followed everybody out to a year, I realized that the week 14 level predicted how great a person was going to be 1 year later, which meant that if I could get a higher drug level at the first maintenance infusion, that patient will probably do better at every 8-week infusion thereafter. And if someone has a really low drug level at week 14, they're going to have a really low drug level at week 22, at week 30. It's not going to change. It's not going to get better, right? If anything, it gets worse over time, and that'll only lead to more antibodies. So it was very interesting that we found that week 14 actually was proactively saying that patients were going to be in remission. Now, what's the true proactive approach? The true proactive approach, and by the way, this week 14 story has been replicated twice. One in ulcerative colitis, that patients with higher week 14 levels had more sustained durable remission with ulcerative colitis, and also in the ACCENT-1 trial, which was the maintenance indication for Infliximab going back to the 90s, they went back to their week 14 drug level and showed that if you had a drug level greater than 3.5, more patients met the primary outcome of ACCENT. So it was kind of all happening in 2014. But the true test of this was Adam Chaffetz in Boston said, I'm going to go one step further. I'm going to actually tell you that I'm going to proactively dose adjust to keep my patient in a range of 5 to 10 at every infusion. So I'm going to have my patients get regular drug levels, and I'm going to call the infusion center and tell them to up the dose. Let's say they would normally get 520 milligrams bottle. He would say, go up to 600 milligrams, finish the bottle. Don't throw it into somebody else's Remicade for that day, for example. And he tweaked his levels. And funny enough, his comparative group, which I think is hysterical, and everyone in front could know what I'm talking about, is that his partner, who had never used a drug level in his whole career, that was his partner's outcome. And Adam had wonderful results. The durability of his patients on Infliximab out to 700 days was extremely strong. And look what happened to those patients who had who never had one drug level tested in their entire tenure with Infliximab. So the idea that, well, now I understand why people say to me that, why are you starting me on a therapy that I'm not going to be on in a few years anyways? I always wondered, where did they get that story from? There's something out there. There's a lot of data suggesting that, especially the one that's made with mouse in it, meaning especially Infliximab, you develop antibodies and develop allergies. I said, that is true. That's how we used to manage IBD, management of biologics, in that reactive way. The Taxit study was another study that actually talked to us, and they actually used proactive drug monitoring as well, where they moved everybody, regardless they had to have been on drug for a while, and they moved them into a drug level of 3 to 7. And they found that once you got someone into a zone of 3 to 7, most of the time, patients did not need another dose adjustment. So it could be that if you get a drug level at week 14, move them into a zone of 5 to 10, 3 to 7's in ELISA, so 5 to 10, let's say. You probably don't need to tweak them very much. And so it's just about proactively getting into the zone that they should be in, maybe double checking one time 6 months later to make sure they're still in that zone, and then let them ride. And unless their CRP changes, unless their albumin changes, unless their BMI changes, all the factors that I noted that could impact clearance, that should be their target for themselves. What was interesting about Taxit is they actually said that almost a quarter of our patients are being overdosed. That shouldn't shock anybody, because if you've ever done a drug level on someone you forgot to lower from 10 per kilo every 6 weeks, and you get a drug level of above 34, and they've been in solid remission, you can all appreciate that we do use too much drug in a lot of patients. Well, what is tomorrow going to look like, since that was the title of the talk? Well, tomorrow is going to look like where you are going to have a computer and an app. You will go in, you will put the patient's BMI, you will put their CRP, you will put their albumin, you will put their drug level, and it's going to tell you what the maintenance dose of that patient is going to be. It's going to say that patient needs 6.2 milligrams every 7.5 weeks. You don't have to worry about it, right? It literally is going to tell you, based on that person's clearance, what that drug level and what the dose frequency is going to have to be. And it will also show you some fancy clearance plots if you really care. So, and this is just telling you that I did this. Those patients I was blinded to, I sent it to a pharmacologist and I said, can you tell me how off I was on my dosing? And 69% of the time, I had the wrong dose for a patient. I was either under or over 69% of the time. I was only right 30% of the time. And that's about what the on-label, if everyone in the rooms thinks about how many patients stay on 5 per kilo Q8, you could probably count them in terms of, after a few years, how many people are still on the dose that you started with. So it really speaks to the idea of individualized dosing. So in conclusion, measurable drug levels are associated with improved response outcomes. Anti-drug antibodies are associated with decreased efficacy. Anti-drug antibodies and drug levels can help guide treatment options. Optimized monotherapy with proactive monitoring may be an effective and safer option. I didn't get to restarting drug holiday, but I'll tell you that these drug levels are really important in you not giving a second drug after you've reintroduced. If you reintroduce someone to Infliximab, please be sure to get an antibody level before you give them their second infusion, because that's when the antibodies and the worst infusion reactions you'll ever see is on the second infusion when you've reintroduced a drug to a patient who has really high antibodies, because the body remembered that it didn't like it the first time, but you may have forgotten or didn't have antibodies from the first time, and you circled back to it. But just make sure before you give your second dose that you have a drug level, and individualized and dashboard-guided dosing is closer than we think. Thank you so much.